Thank you, Catherine, and it's great to see you here today. I've named my talk "How I Went from Clinical Physiology to Global Public Health Policy Without Actually Realising It," and part of the reason for that is it has been a somewhat unplanned journey, but it's one that's actually been incredibly fulfilling. So I'm going to tell you a little bit about myself and just where I've been. So I did medicine in the 1970s, graduating in 1981, and I was then a junior medical officer, largely in Sydney, and I trained in paediatrics pretty quickly. I got into the paediatric training scheme. I worked as a fellow in paediatric, as a clinical fellow, and then I did a PhD between 1989 and 1991 at Kids Hospital, which was then at Camperdown, and then I did a postdoc in endocrinology at Prince Alfred. So you'll quickly work out I was 10 years as a full-time student. I was 13 years after graduation from medicine and not yet working as a consultant, but I can tell you I was enjoying almost every minute of it. And then I got my first academic paid job as a senior lecturer in the department that I'm now the professor of. Started clinical services in my particular area of specialty at the Kids Hospital at Westmead, which had moved by then, became an associate professor, a professor, and then head of school. So I'm still enjoying almost every minute of it, and I'm still clearly hanging around Sydney, and there are a whole lot of reasons for that, not least because I married a really lovely person earlier on, and it was really hard to move. So just like a sonnet is very contained, only has 14 lines, but you can do all sorts of things within that. So the constraints about having to live in Sydney and being able to work just around that focuses the mind on how you might be able to do some really interesting things there without the ability to be able to travel overseas, for example, or interstate and work in other environments. So just a few things to think about. I trained as a general paediatrician, which is actually the biggest training program, and now I'm a bariatric or obesity paediatrician, and I was really the first person in Australia, paediatrician in Australia, who really started to delve into and get very involved in obesity work. And yet when I was a student, there was 6 years as an undergraduate student, one 60-minute lecture on obesity during the whole of the medical course. Now, if you're at the University of Sydney, you'll actually have a whole lot more training in obesity, because I know about that, because I've been involved in quite a lot of that program. It may vary depending upon which university you're at, and yet now it's one of the most common chronic diseases that we see worldwide. I'm an academic. I love teaching. I love research. I love capacity building of young people. I have a variety of other professional roles. I'm very involved in a range of professional societies, both in Australia and internationally. Journal editing, I established a journal, Paediatric Obesity it's called, which is going still strong many years later. Been involved in the NHMRC, National Health and Medical Research Council, and in the Australian Academy as well. I'm a researcher. Initially, my PhD was in nutrition physiology, but now I'm mainly doing clinical and population health research. And I've also somewhat morphed into a public health physician without realising it, and I'm seen as having some degree of authority in that area, which is rather amazing. And of course, the most important part of my life, my family and my community, and I suppose I want to always highlight that for you, that should always remain the most important part of your life, even though I'm passionate about the rest of it. So let me tell you a little bit about my work. You're going to hear about different people's journeys in their work today, and they'll probably, you'll get a bit of a feel about what's common, but you'll also get a feel about what's different between people. I mentioned before, just because there are constraints about where you can work, for example, doesn't mean good things can't happen. My PhD was in paediatric body composition, undernutrition and nutrition physiology in a paediatric hospital. And for my postdoc, I was actually already qualified as a paediatrician then, but I was hooked on research. I wanted to do a postdoc. I wanted to be able to further develop my skills, and I wanted to go into other areas of nutrition, and obesity seemed like it was really important. This was in the early 1990s, and it was. But I had to stay in Sydney because I had, for family reasons. So I went to Royal Prince Alfred Hospital to do a postdoc, the big, bad adult world. You have no idea how potentially scary that can be to a paediatrician. I knew the paediatric world in Sydney. The adult world, a bit different. Would I lose my paediatric credibility? What would happen if I went, at that time, just up Missenden Road to Prince Alfred? Would I become a different person? And it was the best thing I did. I got hooked on the emerging issue of obesity. I worked with a tremendous group of scientists and clinicians, researchers at Prince Alfred, and I got really involved in obesity and pre-diabetes, and I spent 2.5, almost 3 years there, and a whole new world opened. I remain working with those people, even though I'm now fully at the kids' hospital, but it just opened a whole area of research which I would not otherwise have known. So it was a tremendous thing to do. Can I just go back to that? My husband loves reminding me, because after about my second week that I'd been at Prince Alfred, I said to him, I think I've made a big mistake. They're using acronyms. I don't know what they mean. They've got a whole way of talking that's different. It's a whole new area, this whole area of research papers I've got to read I've never encountered before. It's really tricky. I think I've made a big mistake. I've left my comfort zone. Well, 2 months later, no problem. I was there. I knew all the acronyms. I was reading the papers. I was part of the group. And I loved it. But it was interesting. My husband loves reminding me how wrong I get it quite often. It's good to have a support person to keep you grounded. So now I want to tell you a bit about obesity. How would you respond to a condition with the following characteristics? It affects increasing numbers of the population, mainly adults, but also children. Decreased quality of life, increased disability, shortened life expectancy, strong genetic predisposition, it's globally prevalent, high economic burden, a significant contributor to disease, death from other major diseases, and most health professionals are untrained or poorly trained in it. You would be rightly worried. You say, we need to act on this. What about this disease, this condition? It's a strong genetic predisposition, but it's usually only manifest in a given environment. It's highly stigmatised. It's not perceived as a serious condition by much of the community in the medical profession. It's the subject of media voyeurism, those headless torsos, and victim blaming. And affected individuals are seen as less attractive, weak-willed, morally vulnerable, bringing the disease on themselves, and probably of lower value than those who are unaffected. And I would say, welcome to the issue of obesity. And when I was doing my postdoc, I started to realise that this was the issue, and I became intensely interested in this. And I realised I was actually one of the few paediatricians, well, hardly any paediatricians in Australia, and one of the only of not very many more around the world who were becoming really interested in this problem in their communities. So initially I was interested in the epidemiology. Just how much of a problem is it? And I found some epidemiologists to help answer the following questions. I didn't really have any background in epidemiology. I wanted to know about the prevalence of overweight and obesity in children and adolescents. And initially we looked in Western Sydney, then in New South Wales, in Australia and Southeast Asia, and we've been involved in a number of international studies, different groups of epidemiologists, but now there's a core group I work with. We're also interested in it in clinical settings because we seem to see more people with obesity in clinical settings. I'm not going to show you all of these data. We're also interested in the prevalence of complications. And as we asked these questions, we realised that we didn't have any information to help guide our services. It seemed to be, these seemed to be pretty fundamental questions, and yet we were finding it hard to get the data. So I was asking, and my colleagues were asking, how much of a problem is it really? So here, I only have a few data slides, but this is one of them. Here's some data led largely by my colleague Sarah Garnett, the Kids Hospital, looking at the prevalence of overweight and obesity from 1985 until over a 30-year period. You can see overweight in blue, obesity in red, and this is in school-aged children and young people. And you can see that there was quite a rise between 1985 and 1995. And I was doing my 1995 was at the end of my postdoc, and the problem had basically really emerged over that previous decade, but people weren't quite realising it. And then it was continued to be a problem, and it's probably plateaued in the past 10 years in school-age kids, although there's a huge social differential. I'm not showing you those data. Huge social differential. If you live in Western Sydney, far more likely to see young people affected by it than if you live in North Shore, eastern suburbs. And of those people with obesity, more have severe obesity. And over time, there's been more central obesity. I think you know that fat distribution is important, and we looked at a measure of waist to height ratio, and so those above where your waist is more than half your height, and that's increased over that period of time. So there is more central obesity occurring, and that's associated with a range of cardiometabolic complications. So this is starting to give us some real basis for thinking, hey, this is a problem. And it was only because I was able to work with these incredible epidemiologists who were teaching me about how you might access data that was already available or undertake your own studies, which we also did, that we started to be able to answer some of these questions. I was also interested because I was working clinically in this area of obesity by now. We managed to establish clinical services at the Kids Hospital, and that's probably another question to ask. But we were seeing kids with all sorts of health consequences, and we realised it was a quintessential general paediatric problem. You see a child or young person with obesity and you have a whole lot of health problems that might be present, and so you need to have a degree of competence in a range of other areas. So I worked with the subspecialists and allied health professionals to look at some of these complications, and we're continuing to be interested in these. My best friends were the endocrinologists, with whom I still do lots of work. So we undertook a study in Western Sydney. I know at least one person works in the Nepean Blue Mountain local health district region. So this was in the Nepean cohort study. So we looked at kids who'd been born 15 years, who were part of a birth cohort that we were linked into, and we followed them up at 15 years. And we measured a whole range of cardiometabolic risk factors, including insulin and glucose and lipids and blood pressure. And we're showed here, looking at waist for age percentile, but it doesn't, we did the same for BMI, and basically the more the risk factors that these young people, apparently healthy young people had, or the higher their waist percentile was, the more the number of risk factors they had. So these were healthy young people apparently. By age 15, over 1 in 10 had 3 more risk factors for heart disease already present. And this was saying to us, oh my goodness, this is a really significant issue. And we were basically saying, yes, we need to worry about this. And in reality, in clinical practice, we were seeing more and more young people who were on CPAP for their obstructive sleep apnea. So when I was a very junior doctor or a medical student, obstructive sleep apnea occurred in young people, in children, because they had congenital craniofacial malformations. Now, and while we still do see those young people with that, we also see now those who have obesity, and that's actually driving the rise in OSA in our community, in adults as well as in children, and why it's emerged as an important, really important health area. So this is a very significant issue for children. By the way, we actually did a really interesting study looking at the kids with craniofacial abnormalities. I mean, this was led by the sleep physicians, as well as the kids with obesity, and showed that sleep apnea itself is associated with insulin resistance independent of obesity. Anyway, it was what could happen by working with this in a clinical environment. Just the questions you can ask are really interesting. We started to see children, young people with this thickened, darkened skin at the base of their neck, axilla and so on, which is acanthosis nigricans, seeing a lot of these kids with pre-diabetes and type 2 diabetes, which didn't exist when I was a medical student. And then we worked with biomechanists looking at the flatter, wider feet and the foot complications that kids happen. And we were able to document the rise in slipped femoral epiphyses and other major orthopaedic complications. I mean, I couldn't do this on my, I wasn't doing this on my own. I was working with these incredible people, but asking questions with them to be able to use their routine, to use their clinical data to get a bit of a sense of what's going on. And that sort of background highlighted how significant a problem it was. Now, this is when, as we're starting to understand the prevalence of this problem, we're starting to get a sense. So I'm working with, interacting with colleagues overseas, and we're all saying, hey, in a lot of our countries, this is a real issue. Meanwhile, the World Health Organization is recognising it's not just a first world problem, it's emerging as a major issue in low and middle income countries, and saw it as an important global health policy issue. I was involved with the World Obesity Federation to actually put together the data to make that case to WHO, and I can tell you about that later. That was a really interesting process that took about 10 years, and quite of that were just years of my life, but where we were actually documenting this and putting together data from around the world and working with the professional organisation internationally to do this. In just a few years ago, the then Director General of World Health Organisation took the unusual step of having a special commission on obesity, and I was part of the working group on this that came up with a range of recommendations which were not nearly as dynamic as we would like to have them, and we could talk later on about why global health policy or health policy ends up being not sometimes as dynamic as we would like. But there were a number of recommendations, and I want to pick up on a couple of these because they relate to some of the work that I was doing as well. Part of it was actually young people affected by obesity actually need treatment for obesity. When it's so common, it's not just a case of prevention. You actually need to treat people, and yet there's so few treatment available. So we were asking at the same time, how can we treat these young people affected by obesity? At the time that the Kids Hospital opened at its current site at Westmead, almost 25 years ago, there were no treatment services for young people in Australia in any children's hospital in Australia or New Zealand. And so I attempted to establish a service there, and initially it was called a general paediatric service, but everybody just sent me their patients with obesity, and then after a while we were able to establish a formal weight management service. But we wanted to establish the evidence base, and so I had to work with people with experience in clinical trials, my other fellow clinicians, systematic reviewologists down the way, because there was starting to be more data, health services experts and others to address this, and it's still ongoing. So my colleagues and I undertook some of the first clinical trials in obesity management in community settings, in adolescents, using e-communication, using dietary interventions and so on. It was a whole range of people, particularly dietitians that I've worked with very closely, so some amazing academic clinical dietitians. We're involved in a range of with groups internationally in systematic reviews and guidelines development. And more recently we've been interested, and this is something Mark will be particularly interested in, has particular expertise in, how do you implement these things in routine clinical practice? There were lots of studies being undertaken, and I've been involved in quite a number of them. We've had some great acronyms, some great logos, and all sorts of things in so many different areas of obesity, because it was this emerging area and we were there, and we wanted to find out how can we best provide treatment in that sort of environment. So we took advantage of this, trying to get funding to do studies, working together with a whole range of people, developing networks of people, not just in Sydney but around Australia as we did these studies. And of course by then there were hundreds of studies internationally, potentially, and so we were involved in Cochrane reviews. Initially, this one is from 2009, but that really highlighted that there was actually reasonable evidence that could guide the basics of treatment. And by 2015 to 2017, there was so much evidence that we divided them into 6 separate areas. So there's now a whole range of Cochrane reviews on different aspects of obesity treatment in children and young people. And the evidence is still growing. And we were able to document that, in fact, there are good principles for treatment. The major issue is often not how you should treat people, it's, is the treatment available? Can they access it? What's the, where is it available? And there are still major children's hospitals in this country where you can't access treatment, and there are lots of different parts of this state where you cannot access treatment even if you have quite moderate to severe obesity as a child. So this whole issue about how we develop and support the implementation of treatment across the state has become one of the reasons we've worked very closely with the Ministry of Health. And so this is part of my morphing into health services research, because we've looked at how can you upskill a whole workforce looking after children so they've got some basic skills. In one of the approaches that's happened over the last few years working with the ministry and across the people interested in obesity in the state is that we've agreed on some core messages that every clinician who sees a child could use. And these are there, that you can see them there. So they're all based on basic health promotion principles, but we wanted to make it easy for the nurse or the dietitian or the physio or the junior medical officer or the senior orthopaedic surgeon to be able to at least give some just core evidence-based treatment recommendations very simply. And of course, probably the most important part of that will be, so this isn't just for hospital settings, this is for primary care, for people working in any environment. This sort of work, this has taken a lot of time, but just even developing things like this has been part of work as an academic and extending the work you do into real life implementation. Now, that was treatment, but I'm really interested in prevention because we're seeing so many young people. It's different from when I was a child. The world is different now. And there are a whole lot more young people affected by overweight and obesity compared with when I was a child. And so this same WHO policy report actually highlighted the importance of early childhood and getting in early. I've been involved in other areas, but I'm just picking up a couple of things. And so as we wanted to know how to prevent obesity, this was particularly an area I had much background in, and I started talking with health promotion experts, some of whom have now become really good friends. There were a whole lot of people with the initials MPH after their name, Master of Public Health. I didn't know them beforehand, but I've got a whole lot of friends with MPH after their name now. I work with the International Organisation, World Obesity Federation, with the Ministry of Health, WHO and others to ask these questions. And accidentally along the way, I partly morphed into a public health physician and have enjoyed that experience. If you think about treatment or addressing obesity, you need to think about the chronic disease care pyramid, where you've got different levels of treatment provided depending upon the severity of illness. But at the base, the absolute base of that is the importance of primary prevention and health promotion. And as a clinician working in a disease that's so common, I can't just think about the level 3 or level 2 care. I could if I wanted, but maybe I'm just a bit of a magpie mind. I'm really interested in how can we actually stop it happening in the first place. So understanding how we can be involved in prevention is really important. So 1 in 5 young people in Australia are already affected by obesity at the time of school entry. And when we started looking at this, there was limited research around how you might deal with this. So we were interested in the issue of home visiting, which had been shown to be important in improving social and health outcomes of disadvantaged young people. So we wondered if that was relevant in obesity. And so we undertook the Healthy Beginnings trial with colleagues in health promotion colleagues in what is now Sydney Local Health District and Sydney South West Local Health District, and had home visiting by early childhood nurses to mothers in the first 2 years. It was 8 visits in 2 years, most in the first year, and it was aimed at improving family and behavioural risk factors for obesity. We recruited pregnant women from Liverpool and Campbelltown hospitals, and half of them got the intervention, were randomised to that, and half of them got mail-out information. And then we followed them up, and we found improvements in fruit and vegetable intake and less TV time, etc., and a decrease in child BMI at age 2. So if you look at the BMI distributions here, so you've got the red group, which is the intervention group, and blue, which is the control group. And don't worry about, you say, oh, the BMI things are different from adults. Yes, children are supposed to have a different BMI from adults, but basically we'd shifted the distribution to the left, which was a 3% reduction in overweight and obesity at a population level. So this was an exciting finding, and it was the first study to show early childhood intervention reduces obesity risk. And of course, we're interested in how long this effect lasts. Probably not very long. I'm not going to go into those, but we've done a whole range of other studies that are coming together, and we're collaborating with people around Australia and New Zealand in particular, and now more broadly. And we think that we need a suite of interventions across the life course for something so pervasive, unless we could somehow turn the world around, which we can't. You can't just do one thing and then forget it. So we established an NHMRC Centre of Research Excellence into the early prevention of obesity in childhood with people from around Australia, New Zealand, and that's been an incredibly wonderful experience in working even more cooperatively with these people, sharing data. And we have the world's best domain name, earlychildhoodobesity.com. Pretty good, hey? And we're looking at a whole range of things in early childhood obesity prevention. And the most important thing is how can we translate what we know into policy and practice. And we've got a whole range of collaborations, particularly in New South Wales and Victoria, with our state governments as we start to do these. But if all of that research done to date on obesity prevention seems challenging, it's nothing to the work we actually should be doing. If you think about the sectors of influence for childhood obesity prevention, you can see the individual and the family right at the centre, and that's where most of our interventions tend to work. That's the politically safe area to work. But the reality is it's these broader societal and political influences that are absolutely fundamental. It's those sectors that must be addressed, and those which more work needs to be done in, both research work and advocacy. And people like Mark and I and others are involved in some of this advocacy more broadly. So that's just giving you a bit of a feel. I'm going to be happy to take some questions, but I want to just leave you with some lessons learned. I think it's really important to follow your interests, whatever those are. I was interested in food and nutrition, so I've always been really interested in that, so follow those. There's no one path to a great career. You don't just say, I'm going to go, here I am, I'm going to go there. It's interesting the way you go. It is incredible being a clinician researcher and asking those questions in your clinical practice and bringing those questions from clinical practice, being able to implement and change what you're doing. But you have to be flexible and you have to work outside your comfort zone. So being a paediatrician working in an adult obesity area, a clinician in public health, have been areas where I've had to start from scratch again. And it's been wonderful. And you're possibly underappreciated other skills like writing, editing, chairing, teamwork, project management, leadership, probably the things that are going to make the big difference. Yes, you've got to be intelligent. Yes, you've got to have a passion for your area. But if you can't get yourself organised or others organised, you're not going to get very far. I wanted to just say it is great being a clinician, but it's great being a teacher, a researcher, and a public health advocate, and I love all of those. Further, you need mentors and supporters in many places. I didn't say here, just make sure you have a life partner who's going to be really supportive. That makes a big difference. Maintain your friendships. And just because people laugh at the problem you're intensely interested in, like obesity, and I have been laughed at enormous numbers of times about this because it's a highly stigmatised problem, doesn't mean it isn't important. So you've got to be like a terrier and stick at it. And while work can be amazing, your life outside work is a real blessing. So make that your priority again and again and again. So I want to congratulate you on doing medicine and health as a career. I want you to enjoy it and I want you to have an amazing life. So thank you.